The meeting is recorded. Can you unrecord? Yeah, you can. I see the button here to record, but I don't know if I do it from your end. Yeah. Yeah.
And then
I can pause it.
Our methods of prevention not too good. Okay, so post-travel encounters. So when you see a person who has acute traveler's diarrhea that is coming back from travel, you can just treat them empirically. You treat them according to the schedule I just talked about. Only time you need to test is if they have severe or persistent symptoms, or if they've already tried an antibiotic. Say that they're coming from Africa and they said, yeah, I tried some Cipro, I'm still having it. Then you may want to test. And the ISTM recommends molecular diagnostics in patients with these acute severe symptoms, failure for treatment, or with persistent and chronic symptoms. But when you do that, and this is just an example, that when you do that, you're going to often find multiple pathogens, multiple possible pathogens, and it's hard to know exactly what's causing their disease. I'm not going to go into it in great depth, but we published with Brad Connor and Greg Martin a kind of a guideline on how to interpret these multiplex results in traveler's diarrhea. And how to guide your therapy. So the next issue is traveler's diarrhea, antibiotics, and acquisition of multi-drug resistant organisms. So here's a nice map that was compiled by the Canadian CDC, essentially, and summarizing a vast amount of literature that shows that depending on where you travel, you have a higher or lower risk of acquiring multi-drug resistant organisms. And specifically, the one that's been most described is this extended spectrum beta-lactamase producing Enterobacteriaceae. It was a big word, but E. coli and Klebsiella that are multi-drug resistant. And your risk is increased just by traveling, but also if you get diarrhea, it increases. And then if you have any antibiotics, it increases as well. The good news is that it's transient for most. There's some evidence that colonization is by less virulent pathogens, but more is needed on that. And we're not sure about the health impact of these colonizations on these individuals. Certainly, if you have an elderly traveler with your recurrent UTIs, then they may be at risk of picking up a more difficult to treat bug, or a traveler returning to vulnerable households. But really, we still need more research in this area, because there are competing risks and benefits in terms of what is the actual risk of spreading these by travelers, what is the impact of not treating traveler's diarrhea. I'm going to get into that in a minute, and what are the benefits and risks at these multiple levels? And we still don't know all the answers to that. But again, we have come to the conclusion and the consensus that we ought to have a discussion with the traveler about this risk. And that's why, single dose therapy and judicious use of antibiotics should ameliorate some of this concern that we have a lot of questions about. So why do we want to, not prevent traveler's diarrhea or not let it get severe? Well, you've probably heard now, or maybe you haven't, but the risk of chronic GI disorders, functional bowel disorders, particularly IBS, after traveler's diarrhea is quite high. You see here the systematic review of 6 studies. There is variation, heterogeneity in the effect estimate of these by study. And much of that heterogeneity explained by there's a higher risk in younger travelers and in those with more severe disease. And so if you let diarrhea go untreated to be more severe, you have a higher, theoretically higher risk of developing IBS. And so that's why we want to treat effectively and prevent. So how do we prevent? Well, again, there's rifaximin has been used and it works well in areas where there's non-invasive pathogens. And so rifaximin could be used. Right now, we only recommend prevention of traveler's diarrhea with rifaximin in really high-risk situations where the person cannot tolerate getting sick. A person has had, maybe they're going on a very important mission or trip and you want to prevent it. Maybe you have a disease that getting traveler's diarrhea would not be good, such as inflammatory bowel disease or some other condition. And so in those situations, it's okay to consider it, but know that rifaximin is not 100% perfective in areas of diarrheagenic E. coli, like Central and South America. It's maybe 60%, 70%, but in areas like Southeast Asia, it's about 30% or 20% effective. So not very effective depending on where you go. But what's come up new in the recent past, and I think it's worth more looking at, is bismuth subsalicylate as prophylaxis. A recent systematic review here showed that it used to be thought that bismuth subsalicylate was about 67% effective, 60-70%, but a new study came out that had a lower estimate, and so now it's around 50%. There are risks of taking bismuth subsalicylate, toxicity, but is this something that could be tried? I have a lot of travelers that I see, and they swear by it and they use it, and there is some clinical evidence to suggest that it does work. Again, you have to caution against the side effects and any interactions that they're taking. So that's all, and I'm happy to answer questions, or I have some case studies that we can use to guide discussion. So I'll stop there. Thank you.
If you have any question, you can write it in the chat. What they are writing, Dr. Riddle, is there any complication that can occur because of using loperamide or bismuth when we're thinking in an infectious etiology of the diarrhea?
Yeah, so the bismuth, not so much. I mean, I think that it's probably very safe to be used in a variety of enteric infections. The theoretical concern is that if you use loperamide or an antimotility agent in the context of an invasive infection, that can lead to toxic megacolon or worsening of infection. And there are some data, particularly in kids, that show that. But if you look in the traveler setting, you don't see that type of adverse event. And in fact, there are some papers that have been done in the setting of severe diarrhea and dysentery where they've used loperamide and don't see that effect. And so I wouldn't use loperamide alone in dysentery, but if you combine it with a highly effective antibiotic like azithromycin, the risk of consequences is very low. But again, we practice that if you have dysentery or high fever, just take the antibiotics alone. I tell my patients, because sometimes you start out with watery diarrhea and then it turns into dysentery, and I say that's okay. Just if it turns bloody or if you're developing a high fever, just continue with the antibiotics alone. And that's how I guide it. So it's not a concern. The studies that have shown that use different antibiotic class, a different clinical scenario, and so this is the recommended practice.
There are a couple of questions in the chat. They say, do we know how many days of traveler's diarrhea can lead to IBS?
So that's a really good question. So there are data that don't define the number of days, but there are data that's particularly with Campylobacter. I think a recent study just came out by Madison Grover and Mayo, not in a travel setting, but in people who got Campylobacter in the United States. And I think it was around eight days, that if it's longer than 8 days, then you're more at risk versus less. But we don't have a cutoff. And so, again, this based on what we do know that, having more severe symptoms, having bloody diarrhea, and actually treating with antibiotics increases, traveler's diarrhea that's treated with antibiotics is also higher risk. However, people who are treating diarrhea with antibiotics also have more severe disease. And so that kind of, it's confounding in terms of the antibiotics with that. So people with more fever have more likely to have IBS, but we don't have a pure cutoff or a kind of a risk score. But the general thought is that the less damage you do to the gut through an infection, the less likelihood there will be this abnormal dysregulation of your immune system in the process that leads to IBS.
Mm-hmm. The other question is if azithromycin resistance is something seen worldwide as it's been seen with STDs.
We are seeing azithromycin resistance, particularly in Southeast Asia, for a number of pathogens. Again, there's diarrheagenic E. coli, there's enteroaggregative E. coli, Shigella, Campylobacter. Those are all kind of the leading bacterial causes. And there are pockets of it here and there. But what we've not seen is, we need to distinguish between microbiologic evidence of resistance and actual clinical evidence of resistance and treatment failures. And we've not seen, so while there is evidence in MICs or measures of the risk or the resistance in vitro, we've not seen clinical failures of people who have been treated with these. And so I think we don't fully understand how microbiological evidence of resistance maps with clinical resistance, but that's something we need to watch out for, is to see if there's treatment failures, and it's just not been well described yet.
The next question says, to which destinations are you prescribing self-administered antibiotics?
That's a good question. So the way I practice is unless somebody is going on like a cruise ship, I will often talk to them about you probably won't need antibiotics, but they'll say, well, I'm going on these excursions and I'm going to be eating on the economy, and so in that case I will give them some antibiotics. If they're going to Europe and or somewhere higher income, then I won't. But for the most part, I will give people a standby course, but very specific instructions on, again, when to take them and how to take them, and again emphasizing single dose therapy as the norm to reduce that antibiotic exposure.
The next question goes along with that. Any concern for the rising rates of global antimicrobial resistance in consideration with the therapy, prophylaxis, or therapy?
Yeah. So this is a whole topic in and of itself. I think this is something very serious. The risk of antimicrobial resistance worldwide, the rise of it, the potential of having infections where we don't have antibiotics to treat them. That's a real threat. What's lacking right now is that there is not a compelling evidence to suggest that travelers have anything to do with that rise of antimicrobial resistance. If you look at the epidemiology, the rise of antimicrobial resistance is due to the high use of antibiotics in animal husbandry practices, as well as many parts of the world, as we know, that have you can just go to a pharmacy and get antibiotics and don't need a doctor's prescription. So there's a lot of clinical use that in many countries, and often we see this is where the resistance is rising, and the traveler use of an antibiotic in that setting is likely not contributing to that rise in antimicrobial resistance. So the other then is the traveler getting something and then bringing it back. And, you know, the fact of the matter is, if you just travel, you get colonized. If you take antibiotics, you get colonized. You have immigrants, migrants, visitors, you know, coming to the United States all the time, bringing their flora with us. And so really, you know, what is the contribution of the individual traveler to the spread of antimicrobial resistance is also uncertain. There certainly are some cases where colistin resistance was first identified in a traveler who returned, came from India and traveled to the United States. But again, those are often people who have had healthcare exposures in a foreign country and then come back. And so really what we're trying to do is minimize healthcare exposures as well, where we know that you're at risk of acquisition of these things through use of self-treatment. And again, judicious use of self-treatment. So it is a concern. We need to follow it. We don't yet know for the average traveler what that acquisition of ESBL does to them. Again, it usually sheds within 6 months and won't cause any health problems. But again, it needs to be studied more. There are multiple sources of antimicrobial resistance spread through food, through migratory birds, and you know the role of the traveler is not zero, but it's also not well understood. And the fact of just traveling and getting diarrhea and increasing your risk of acquisition argues that, you know, well, you also need to treat the risks of not being treated for traveler's diarrhea with IBS, or having to then access the healthcare system because you have a severe case, or argues against judicious use when you have moderate to severe disease. Perfect.
Dr. Riddle, we have 3 more questions. I don't know if you want to proceed with the cases and then go to the questions.
I think it's good. If they have questions, I think they're good. So
okay, perfect. The next question is, what about the use of Dukoral for prevention of enterotoxigenic E. coli?
Yeah, that's a great question. So Dukoral is a cholera vaccine that includes the toxin, cholera toxin B subunit, which has, I think it's 98% homology to the heat labile toxin of enterotoxigenic E. coli. And so that the cholera toxin and the ETEC toxin are essentially, you know, twins. And so this cholera vaccine has this toxoid to prevent traveler's diarrhea, to prevent cholera, and it has some cross protection against ETEC. The problem is ETEC comes in 3 different flavors: LT, ST, and then combination LT-ST. And LT is about 1/3, and LT-ST is about 1/3, and then ST is about 1/3. And the antibodies to that only are, I think it's 29. A study was done out of Spain, and it was 29% effective against ETEC disease. And so it could be used. I think ETEC is but one illness that you can get. Enteroaggravative E. coli is very common as well. And so you're still going to have standby therapy antibiotics to treat the other causes that you might get. And what's the risk benefit of that? The other thing about cholera vaccine, it's been only shown to last about 6 months. And so it's very short-term protection. You need to get revaccinated almost prior to every trip.
Yeah. The next question is, how do you manage malaria prophylaxis in the context of traveler's diarrhea?
Yeah, so I generally will give Malarone unless I think that the patient will have a freshwater exposure, and I want to kind of cross cover for a lepto for that. But so there's no problem with that. Actually, with doxycycline, there's a lot of mixed evidence. There's some studies that show that doxycycline prophylaxis for malaria has some preventive effect for traveler's diarrhea, and there's other studies that show it has no effect. And so it may be that there's a local resistance, geographic resistance to it. And so I don't worry about interaction, and I wonder about the potential efficacy in prevention, but the studies are mixed.
Gotcha. The next question is if there is any particular potential side effects of the antibiotics that you consult your patients before prescribing treatment for traveler's diarrhea.
Yeah, that's great. So, you know, I argue that, you know, or I don't argue. I tell them that, you know, with single dose and any antibiotic can have an adverse effect. Many people have already had a Z-Pak already, you know, or they've had a fluoroquinolone, and so you know, they're pretty comfortable with that. And so I will tell them with the azithromycin, if they've had GI upset before, then that they should divide the dose instead of, you know, or take 500 milligrams, or they could divide it if they really are sensitive to that in a split dose. But you know, otherwise, you know, there are the risks of with fluoroquinolones and Achilles tendon tendonitis and tendon rupture. But again, when you look at the data, that's the longer you take that medication, the more likely you are to develop those symptoms. And so again, I'm stressing very short durations of these medications, and then the risks of those side effects are very low. QT prolongation is important. You see that in a lot of elderly travelers that are on other medications, or not just elderly travelers. You know, you should, you know, or one practice is people actually get an EKG while the person is on drug, just to document that there's no QT prolongation, or that QT prolongation is not worrisome. But others say, well, you know, this is a single dose. The likelihood of the adverse event is very low. And so I'm going to give you this. Or people will say, let's do rifaximin, and knowing that rifaximin will not be as effective, but it's safer. And so those are kind of how you manage the common side effects.
The last question is any update on novel vaccines?
Yes. So this is, I used to have a slide and I should put it back in, but there are 3 vaccines that are on the horizon. One is a Shigella vaccine made by Limitech and GSK, and it's been shown to be effective in a human challenge model for Shigella. It's now being tested in a pediatric population in Africa, and there are plans to, or there's hope that those will you know, develop into a traveler vaccine. Norovirus is a vaccine that is also just been out licensed to Hillavax from Takeda, and I believe they have a traveler indication program. And then there's an ETEC vaccine that has just been shown to be effective, interesting against all-cause diarrhea in Benin, Africa, with moderate protection against ETEC specifically in a phase 2 trial. And I believe that that's evidence to support continued development for the traveler. So those are ETEC, Shigella, and norovirus are on the horizon, and all of those would be great travel vaccines.
Great. Thank you, everyone, for such an interesting questions. And I think we can go with the cases.
Great. So first case is a 62-year-old female with a history of recurrent UTIs. She has about 2 to 3 per year, traveling to India for a vacation of a lifetime. She has experienced severe traveler's diarrhea on prior travels. She has past surgical history of hypertension, moderate chronic kidney disease, and her current meds are enalapril and a multivitamin. So the questions are, you know, what makes this person high risk for traveler's diarrhea and consequences? And I guess this would be where people could write into the chat, or
yes, please write in the chat the answer. They say antibiotic resistant, ACE inhibitor.
Yeah, so I would say that the person has chronic kidney disease, so a dehydrating illness could have impact. Yes, previous severe episodes, and that recurrent UTIs is also a risk factor for this person getting a multi-drug resistant organism, and destination. Yeah, those are all good. what counseling intervention do you give her with respect to preventing traveler's diarrhea? So I will comment while people are adding their stuff in that, this idea of boil it, peel it, cook it, or forget it, that you can control your risk for traveler's diarrhea by behaviors, by avoiding ice. The evidence would suggest that there are so many different ways to get exposed to traveler's diarrhea that it's difficult to control those exposures. And so our counseling is not all that effective. There are data that would suggest that if you can only drink from approved, from treated water sources, then you have a decreased risk. But the counseling for prevention, we say it, and we ought to do it because there are studies that show that ice or salads are in outbreaks of traveler's diarrhea, are are responsible for it. But again, in studies where they actually measure people's behavior while traveling, those that have those good behaviors and those that don't have those good behaviors get sick at the exact same rate. So I'm seeing some great things, staying well hydrated, that's good. Standby antibiotics, I think that's good. One could consider in this patient a rifaximin, but at the same time, she's going to India where there are a lot of invasive pathogens and it may or may not work. So, this would be a tough call. This is kind of a gray area. Good idea. Yeah. If she comes back and gets a UTI, get it cultured so you know how to treat it. Probiotics, you know what? The probiotics data is inconsistent. And we are so hopeful that, because we know that the microbiome is associated with acquisition, colonization resistance, but we just don't know yet how to target the microbiome to prevent traveler's diarrhea or prevent acquisition yet. But there's a lot of groups that are working on that. Travel insurance for this person would be key as well. These are you guys got it. All right. So what empiric standby therapy would you treat her with, or would you treat her with, and give her guidance? So standby therapy. In this one, again, Southeast Asia, azithromycin. I would tell her as soon as it starts impacting to take it, and take it. Single dose should work with loperamide for watery diarrhea. If she has dysentery or high fever, just take the antibiotics alone for 3 days. Cesar, how much more time do we have in this session?
We have 6 more minutes.
Okay.
Oh, sorry. So, 10 more minutes, actually.
Okay, good. So what should you tell her to do? Should she develop a UTI? That's been mentioned already. So she should get her urine cultured to make sure she's treated properly. All right. Next one, traveler number 2, 38-year-old male with a history of ileocolonic Crohn's disease, traveling to Nepal on a trekking trip, status post ileocecectomy with primary management on immunomodulator 6-mercaptopurine. He's been stable with only a couple of flares. He's fecal calprotectin negative, and his last colonoscopy was mucosal inflammation was negative. And he's on medications looks like to bind bile acid due to his ileocecectomy, and supplementation for nutritional. So what counseling intervention would you consider with respect to preventing traveler's diarrhea in this patient? Well, I might say, given that you have Crohn's disease, it's fantastic that you, sent to a TD specialist. Yeah, this is a complicated patient. I would say, listen, you have Crohn's disease and it's quiescent now, and that's great. But we know that, flares will occur. We know that it's been described that in people with inflammatory bowel disease, that an infection, enteric infection, can cause a flare. And so with this individuals, I would say, do you really want to go on this trip? I mean, is this the right thing for you? And have that discussion, and probably, yeah, why the need for the trip? You know, again, young person, you know, who knows why? But I would this is where I would probably reach out with their gastroenterologist and say, hey, did you know that Mr. Jones was going to go on this trip? And you know, have you talked to him about it? And what do you think? And so I would definitely kind of coordinate care with this one. But if this individual absolutely wants to go, you know, for you know, people have individual choice, then you know, what counseling do you do? Again, you know, best you can avoid exposures, knowing how hard that is. I would consider in this person prophylactic antibiotics, and I would use rifaximin, you know, for that. Again, knowing that, you know, Nepal has invasive pathogens too, but they also have a lot of diarrheagenic E. coli that this person could be exposed to. So I would, these are great. I would, yeah, pack your own rations. I think this is a travel that needs to take special care in terms of how they're eating and what they're eating, and have those discussions. So those are good. These are complicated travelers. Yes, rifaximin is best studied in Mexico. Does it work in Nepal? There's a study that a phase 4 kind of efficacy study that included travel to Southeast Asia. I don't think they broke out Nepal, but it was India, Nepal, and areas there. And they showed that I think it was 35 or 40% protective in those Southeast Asia. We did a study in the military that included travelers in Southeast Asia and high-risk regions, and it was 30% effective. So it is best studied in Nepal. Again, in this traveler who has a risk of a flare after infection, I would opt to, I would opt to try to prevent any disease. And I think that it's even though it won't be as effective in Nepal, it adds an additional protection for this individual. And so I would also, so that's what I would consider. What empiric standby therapy for traveler's diarrhea you give him, and the guidance on when to treat? What do you think? You know, so again, Southeast Asia risk for fluoroquinolone resistance, azithromycin is the choice. And I wouldn't change any therapy other than I would say, again, I would tend to treat earlier and not wait, so that you can mitigate any inflammation triggering and zithro, and follow the guidelines. Perfect. What other IBD related risks does this traveler have for which you could provide counseling? So there's a, you know, IBD subjects, yeah, immune suppression, absolutely. So this person is at risk for just infections, disease, you know, it's T cell suppression. So viral diseases are a problem. Anemia, so associated with 6-MP. So, you know, if he's trekking in Nepal, he may have some hard time in some high elevations due to some anemia. And then everybody with, is parasite risk increased? I would say, you know, that's a good question. I don't know the answer to that, but I'm just thinking, since T cells are likely important for that may be important, but that's a really good question that's come in. I don't know the exact answer to that. There's probably not data on it, but there's probably a biological best guess, but I'm not going to posit that right now. The other thing with IBD patients or you know, autoimmune patients is that they have high risk of thromboembolic events. Even if they're well controlled, they have just a high background of pro thromboembolic state, you know, 2 to 3 times risk. And so with this person traveling, on airlines, really counseling, I think, on getting up and walking, moving around, and reducing the risk for any DVTs, would be an advice. Good. All right. Last one. We have a traveler, 33-year-old female, traveling on a week-long honeymoon to an all-inclusive resort in Mexico. They are adventuresome travelers. Frequent traveler doesn't recall getting traveler's diarrhea on prior trips. Recently diagnosed with reflux disease and started on a PPI therapy. Past medical surgical history, non-contributory. Okay, so this is your average traveler. So what do you think? How would you classify the traveler's diarrhea risk in this 33-year-old female honeymooner to an all-inclusive resort in Mexico? Yeah, moderate is good. I mean, one could argue that all-inclusive resort, but the fact that they're adventuresome means that, maybe they're going to do some off resort excursions, and so that's probably puts you in the moderate category. PPI risk does increase risk of infections. Although the data there's just not good data in travelers. There's a couple of studies, and one found no real evidence of PPIs. But there's a number of other studies just in domestically acquired infections that show increased risk of GI infections. And so, yeah, I think that this person would be at risk for that as well. And Mexico is a hotbed for ETEC, that's for sure. So yeah, I would say moderate due to the comorbidity as well as being an adventuresome traveler. What counseling intervention do you give her with respect to preventing TD? Well, I think that what we've talked about, good hygiene, be careful what you eat, but know that that's not going to, not going to solve the problem, and that we should give you standby therapy. And again, follow guidelines. I would give her the azithromycin, loperamide. Again, guidance on the risk for MDRO acquisition. If she should get a UTI in the 6 months following travel, she should get it cultured. Could you use rifaximin here? Yeah, I think you could. So this is the issue, though, right? So how do you know they're not going to get Shigella in when they go? Shigella's endemic in Mexico as well. And so you'd have to, if she got Shigella, then the rifaximin wouldn't work as well. And so are you going to give her rifaximin and azithromycin? Maybe you could say, hey, watery diarrhea is most common. I'm going to give you this medication, rifaximin, works really well. But if you get dysentery or high fever, you need to go to the hotel doc and get something else. I mean, that, or do you just give azithromycin single dose, and which works brilliantly for ETEC and interaggregate E. coli that are common there. So these are tough. I think rifaximin wouldn't be a wrong thing here at all. I think it would be good. It's just you'd have to have that discussion about, okay, and if this fails and you have dysentery, what are you going to do? So this is great. Thanks for your thanks for your input. And are any other questions? Thanks for your feedback. I think the other thing I'll just mention is that there are studies coming out on the probiotic front and the passive immunoprophylaxis. There's a couple of products out there by Fluorostor, and I forget there's another one. And the military is actually doing a study right now to look at these non-antibiotic modalities in prevention of traveler's diarrhea. Those results should be out next year. And we need more preventive therapies. I think we need to relook at bismuth subsalicylate too. I think another study is needed to look at to see if bismuth subsalicylate has a preventive efficacy as well. You know, this is an exciting area. We need to understand how to decolonize people after they come back. We need to understand how to prevent colonization of MDRO. But the good news is we have really good single dose therapies, and this is the bread and butter of travel medicine. You know, traveler's diarrhea is often number one or number two on the topic list. So thank you.
Thank you so much, Dr. Riddle, for these sessions, and thank you so much, everyone, for the participation and interaction in this case. Just as a reminder, there is another round of breakout sessions that's going to start at 11:50 Eastern time. Check out your agenda and join to the breakout sessions that you choose. And thank you so much, Dr. Riddle, again.
Sure. Thank you all. Have a good rest of the meeting. Hey, Caesar, I'm going to step away. I'll be right back, okay?